I'm Derek Parsons from Parsons Benefits Coach, and with me today is Matt, Business Development Executive from Imagine 360. Matt, thanks for joining me today.
Derek, thanks for having me. Great to be here.
So today we're going to talk about reference-based pricing. We're going to talk about where it came from, what it is, and how it might be a good fit, how it applies to you and your organization. Does that sound about right?
Absolutely. I'm excited. I live RBP, so let's get this thing rolling.
So tell me a little bit about RBP. I mean, we use a lot of acronyms in this industry, which isn't great. What does RBP stand for? Tell me a little bit about it. And, how did it come about?
Yeah, it's a great question to start. And I love to tell a story about how I start explaining this. So a few years ago when my daughter was 5, I was driving her to school and she said, "Daddy, tell me more about what you do for work." And I'm thinking, how do I explain reference-based pricing in healthcare to a 5-year-old?
I went to college.
Yes, exactly. That's that. I went to college, so no more questions, right?
Yeah.
So what I said is, okay, well, Daddy tries to help people get to the doctor and find a fair price for their care. And she thinks about it for a minute and says, "Daddy, how long does it take you to drive everybody to the doctor?" And I'm thinking, okay, the mind of a 5-year-old. But in spirit, that's really what we're trying to do, is make sure that the American population, your employees, can actually get and receive care and not break the bank. And so there's a myriad of ways that we do that. This started in its infantile stages in the late 2000s and has grown quite a bit since then. We wrote our first client back in 2007. They're still a client today.
Wow.
And we're just seeing as costs are going up in the health space, right? And that's not going to reverse itself. So this is a way to kind of help at least contain those costs for your business and your employees.
So do you know who originally created reference-based pricing, and like how did that come about? Do you know any of the legacy story?
Yeah, it's actually our 2 founders, which are still with the company. I sat in the hopper one day and just said, how are we going to fix this? And again, this was almost 20 years ago. So you can imagine how things have changed since then. And I think just looking at it, they said that these costs are absolutely out of control. There's no regulations on what doctors' offices and hospitals can charge. How do we reverse that? And I think that their thought is, let's start with Medicare as a baseline. And I can kind of give you just a little bit of math on how this works, not to totally confuse people, but essentially how it works is every facility out there has to disclose their cost for care for every one of the procedure codes. So once we have that, that's where the CMS starts Medicare. So Medicare is typically going to be about 25% or so above that. So you have baseline cost, then you have Medicare. The problem that we have is that hospitals have no regulations on what they can charge. There's not to say, hey, it has to be a certain percent or we're capping you here. So you and I both sit in California. For California, the average is right around 450 to 500% of Medicare. So for easy math's sake, you're talking about a 5 times markup. How that's passed along to the consumer is when you have a typical plan. So think of your Aetnas, your Cignas, your Blues, the name brands that people are familiar with. They're typically getting about a 50% discount. So again, with easy math, 500%, you're still at 250% of Medicare, which really is an insane markup. And that's not going to work in really any other aspect of our society. So what we do with reference-based pricing is instead of that top-down formula, we look at bottom-up. So we take that Medicare level and we will reprice that claim after it comes in at 20% above that. And that is going to filter down to not only what the employer is going to pay in a self-funded plan, but also reduces the cost for that actual employee.
Let me prime this conversation a little bit just for our audience so that helps them understand what we're talking about and why it's important. Employers offer benefits to their employees. Most employers look at their benefits plan as a attraction and retention tool. It's a attraction and retention tool to keep really good employees in the company and from losing them to a competitor. I mean, turnover is very expensive, and I think most employers would agree. But The alternative to that is dealing with double-digit increases on fully insured health plans. Is just it's taking more and more of a bite out of the budget for most employers. I mean, it's a huge line item. I mean, aside from payroll, it is one of the biggest costs for most employers. And when we've talked about canceling benefits because of these increases, I think that it's an interesting conversation with employers, but most of them do not cancel benefits. And they're paying for insurance. They're just trying to figure out how to make it more affordable while giving their employees great coverage so that they're taking care of them and we don't lose them to a competitor. So reference-based pricing is a part of self-funding, and it really comes down to how you pay the claims and the amount of dollars that you're spending on each claim. Does that sound about right?
Yeah, that's correct. And I think a few things there that we can talk about, just the problems out there that businesses are having. And you hit on it right on the head. There's a ton of increases. So costs are going up year after year. It's growing exponentially. And what does that mean for businesses? Well, it means that they have to account for those dollars. And how do you do that? I mean, you cut staff, you pass that cost on to your employees, meaning you've got to increase their contribution levels. You've got to reduce your plan sometimes, which means that you're raising the deductibles, you're raising their out-of-pocket max, and as you said, the turnover is very expensive. And if someone sees an increase in their benefits, they might go down the road for perceived better benefits, or even $5 more an hour. So those are the issues that really are facing employers today. Some of the positive outcomes that we look at when we do reference-based pricing, we kind of talked about how the math works a little bit earlier, is you're looking at a lower cost point, and that's something where you can help pass that along to your employees. So if you're able to reduce your costs, say 25-30%, which is a lot of what we're seeing in the market, well, you just went from a 10-15% increase to maybe a 25% decrease. So that frees up a lot of money, and that allows for the employer to pass that along to their employee, which can mean a better health plan, lower deductible, lower out-of-pocket costs as far as contributions, and that's really where we see a win. And those funds can be reallocated. Can I tell a quick story about something we saw recently? So we had a group that came to us, and they were about 500 employees and a construction company, which is a great industry to talk about, because you're looking at fair amount of turnover, low profit margins, things like that. And they had they were fed up with the healthcare system today. We're just getting cost after cost. I don't know if we can stay in business if we still want to be able to provide healthcare to our employees.
Common conversation.
And just be able to keep our doors open. So we did the analysis, and we were able to project about a 25% savings, which for them in that first year was between $500,000 to $600,000. So let's fast forward to now 4 years in. We've saved them over $2 million in their health spend. They've increased their health plan, the performance of their health plan. It's a stronger plan, lower contribution levels, and they've even gone as far as to build an on-site clinic for care for their employees. So again, more cash flow.
So they had enough savings from implementing reference-based pricing and a self-insured plan to build a clinic on site.
They were able to build an on-site clinic, so their employees could go get care where they work, which again, the nice thing with that is it's very accessible, and you can catch things early too, just from talking about the health of an employee is a whole nother subject that we can get into.
Does that mean that they hired their own nurses or doctors to run the clinic? How's that work?
So they were able to provide that on-site clinic with nurse care and just your basic PCP care. And so if somebody needed something more, they'd be referred out to a hospital, to a facility. But, for the basic needs of their employees, they were able to put that on site and provide hours where their employees could go in.
It's almost like a miniature direct primary care, model, or like concierge medicine model, or even like a Kaiser model. I mean, it's kind of how Kaiser started. a long time ago, Kaiser Permanente, is that healthcare costs were very expensive, and having something that was owned by the company was a whole lot cheaper than buying insurance through the open market.
Yeah, and I think the two, aside from just the accessibility of care, the other two positive impacts that it's had on them is, number one, just more cash flow because they are saving on the healthcare expenses, and two, their retention rates have gone up, and they've been able to attract new talent, which again is great for business, but also impacts the bottom line. You said it earlier, Derek. I mean, it is expensive when somebody leaves. You have to train, you have to rehire. That takes time, that takes resources. So if you can improve your retention rate by 5 to 10% simply by offering a really quality health plan that's affordable for the employee, that's going to be a big win for your business.
Yeah. Once employers get it, man, they get it. I mean, sometimes it takes some time to educate and get them to feel comfortable with self-funding and reference-based pricing. But once they get into it and they see the savings, I mean, it's nice, it's refreshing. It's refreshing to come out and not deliver bad news every single year.
And it starts with just education, right? I mean, this is something where we're sitting down today to kind of just scratch the surface and kind of let employers know, let people know out there that they don't have to be stuck in that fully insured death spiral of renewal after renewal. And there are ways to get out of that. And this is certainly one of them by looking at self-funding, which essentially means you're going to be paying your claims, so you have complete insight into your health spend, which I think is very important, because today, if you have a fully insured plan, all you know is that you're getting a bill every month. So the carriers, you got a premium, they send you a bill, you pay it, but you have absolutely no idea where your spend is going. If you go the self-funded route and then add a layer of reference-based pricing on top of that, you literally know where every single dollar of your spend is going, and that can be refreshing. So I think it just starts with conversations like this, just what we're having today, where we can educate and just show that there is an alternative route out there to how you're going to control your healthcare spend.
So I had an employer that I worked with that they were spending about $1 million a year, and they went from fully insured into self-insurance. In the first year number one, they ended up saving. It was a lot of work. It was a lot of work, plan summaries, SPDs, hiring a TPA. It was a lot of work, but that first year they saved about $400,000, and they were paying them about $1 million a year every single year. And what they were concerned with is that they just didn't feel like their employees were using the insurance that much. It was interesting conversation because it's not that they couldn't afford it, because it's more of like techie. It was like a tech company. It wasn't that they couldn't afford it. It's just that the issue is that they weren't sure people were actually using it, and that they were just wasting money. So that was a really good move for them.
And it's interesting you mentioned that, because if you do have, let's just say you're a business owner, you're a CFO, you really don't know what your utilization looks like on your plan. And for I think you put a great example on the table where, tech company is going to be a lot of younger people, a lot of young male population. They're only going to the doctor if they, break their ankle playing pickup basketball, right? I mean, they're just not using the plan. And so by just paying a premium, you're leaving a lot of money on the table, where if you have low utilization simply because you maybe have a healthier, younger population, by going the self-funding route, it doesn't surprise me that you were able to use that stat or give me that number with that type of industry. But I mean, that was a great move for them, right? Because they can actually see the savings and know where their spend was actually going. And there's another side to that too, Derek, that I think is important, is that when you go the self-funding route, not only do you have the transparency, but you can make educated decisions going forward about your health plan. So, if you notice, just for example, that in your population, you see some dialysis claims, you see the diabetes issues start to tick up. Well, you can add a solution for that and help contain those costs. You can use and add a telemedicine. That got very, very popular during COVID. And I think that there is value in that, because for kind of simple things that instead of trying to make an appointment, going in 4 days later, you can simply get on the phone real quick, talk to the doc, maybe get a prescription, and if you need one, and then you're on your way. So I think you're spot on with just looking at where is my spend and why am I paying these rates every month when I have literally no idea where it's going.
Yeah. Give me an idea of the average client size that you work with. I mean, at what point in either premium or employee count should an employer start thinking about self-funding and reference-based pricing?
Yeah, it's a great question. And, really the magic number is right around 100. So if you have 100 employees that are benefit eligible, I think it's worth having the conversation. And then we can figure out a solution. Every group is different, and every group's going to have different things that are important to them, right? And so, it could be the cost savings. It could be access to care. One of the things with RBP is that you really have an open access plan. So employees can go where they want for care, rather than dealing with a restrictive network, which may be difficult in their area. Or they really want to go to facility X, but that facility is not in network. So essentially you almost can't go because you're going to be paying that really high out of network rate. So I think just for the purposes of, if you're listening out there and you're around that size, or you're larger, even multi-hundred, multi-thousand I think it's a good starting point to just have a conversation. I mean, I think you as a consultant, you want to listen to what's important to any of your clients, any employer that you're talking to. And we want to do the exact same thing, because we know that everyone has challenges, and we just want to listen and figure out if there's a way we can meet those challenges.
Yeah. If you're doing an analysis on whether how do you explain self-funding to an employer that's been fully insured and they don't have a clue, in a very quick way, I'll say, look, self-funding is like owning your own insurance plan. You are hiring a third-party administrator, which is a TPA, and then you are picking a network. Typically the Blues, and that's the largest network in the world, United Healthcare, Aetna, Blue Cross Blue Shield. In most states, it's the same company. That's the one thing a lot of people don't know. In California, they're separated. It's one of the only states there's two separate companies. And then you start looking at your pharmacy benefit manager, your PBM. How do you build your formula for prescriptions? And then you're going to have cost containment services and tools. And then the last thing is your stop loss, your protection. So those are all like cogs to the spoke, and they all kind of work together. I think the important part is that reference-based pricing is one cog to that spoke. And it's a very effective and impactful cog to that spoke. And I don't think a lot of people realize that most of the Blues, when you go to a hospital, you're paying 300 to 400% of what Medicare pays for the same services. And I just don't feel like that's fair. To speak to your point about having open access, man, that is nice, because most of the providers out there take Medicare.
Yeah,
most do,
and
more so than the Blues. And if you're willing to pay them, it's like a cash payment almost, that is more than Medicare, and you don't have to jump through all the hoops of getting it pre-authorized with the Blues or United Healthcare or Aetna, I mean, the providers typically like it. They get paid quicker. There's less admin and work to getting paid, and they're getting paid more than Medicare.
And if you can get $1 more than Medicare, wouldn't you take it? You're right. I mean, about 55 to 60% for most hospitals out there, that's the Medicare business, and that stands to reason, right? Because you look at with the high dollars, you're looking at the knee replacement, heart issues, hip replacement. That's typically going to be the older population, so they're on Medicare. That's driving a lot of the business. So without any hassle or any red tape, if you can get we reprice at 120%, so 20% above that Medicare cost. That's a huge win for those facilities. And one other piece, because we do get the question where if I can get these Blue discounts or Aetna discounts and I get more, why would I take a reference-based pricing plan? And the answer, number one, as we just talked about, is you're taking 60% of your business is Medicare anyway. So if you can get more than that, that's a win for you. And the other piece, I'll use the hotel analogy here. So if you walk into a hospital and you go around, you see empty beds and empty rooms, that's lost revenue for that hospital. So anytime someone's not, and we use the term butts in beds, anytime we don't have somebody in that bed, that's lost revenue. So with the hotel analogy, if a hotel wants, they want to get $300 for a room, but they have 20 empty rooms, and this is where we see those last minute deals. If they can get $200 and fill 10 more of those rooms, that's still a huge profit for them, right? They're still making money off of those what would be unsold rooms. So that's why our acceptance rates are really high. That's why a lot of systems are embracing this, because they do want those people in their beds doing the procedures. One other thing I'll mention about that as well is we live in a competitive landscape. I mean, you and I both sit in California. I mean, it's countless how many health systems we actually have out here. We have the UCs, the Sutters, Stanford in the Bay Area, John Muir. I mean, the list goes on and on. And so these hospitals are all competing with each other to get business. I mean, you have to look at a hospital like you would any other business, that they need customers, and someone receiving a knee replacement is a customer. So they're going to want to get that person in their facility. So that's just one other way of looking at it.
Do you think there is, in your opinion, do you think that there's any coercion between hospitals trying to keep rates high?
The collusion question.
Yes.
It's been brought up before.
Coercion?
Yeah, collusion. Coercion. I think they can be two in the same, right?
Yeah.
No, I just think that they're again competing with each other. They don't want to tell what the other is doing, and it's really just a hard thing to try to shut down, be it with either carrier negotiations or with the acceptance of reference-based pricing. They want to keep their cards close to the chest on those type of situations. So no, I don't. In the conspiracy theorist in me would love to say yes, but no, I don't think that's happening in our market.
This is a great topic, and I think there's a deeper meaning to this conversation, and it doesn't need to be an employer conversation or an HR conversation. I mean, the cost of care is going up, and we've talked earlier today, and most people can't answer the question why. Why is your healthcare going up 10% every year?
Yeah, and that was one of the things that I recently had a chance to speak at a conference, and about 500 people in the room. Wasn't all benefits people, but first question I asked was, how many of you are in charge of the benefit plans and benefit spend? So a few hands went up, and then my second question was, how many of you have seen increases in the last 2 to 3 years? And I swear more hands went up than the first time I asked the question. So that's the awareness. My next question is, does anybody know why? Yeah. And it was crickets in the room because, well, first of all, 500 people, not too many people are going to want to raise their hand. But second, I think it speaks to the fact that we just don't know. I mean, healthcare is hard, and without transparency, without a real look at, okay, I have my bill, but it's just premium. It's head count, it's premium. I really don't know what I'm paying for. That really is the reason for that people just don't know why.
Yeah.
And you and I have talked before that healthcare is the only entity out there where you don't know what your bill is going to look like when you go into that facility. It's not like they have a menu or list pricing, knee surgery, $80,000, something like that. So you don't know what that cost is going to actually look like.
Yeah.
And so, you go to Macy's, you buy a sport coat, you see the price tag. You go to a nice restaurant, you know what the prices are. You might see market price on a really nice lobster or something, but you can ask what that costs.
Yeah.
When you go to a facility, and even for that matter, a doctor's office, you're going in blind. You don't know what you're going to pay.
Yeah.
So when that bill comes, it's a complete surprise to people.
And you can ask them, and they're like, well, we don't really know.
Yeah, you can ask the doctor,
Yeah.
what's this going to cost me? The doctor has no idea. The doctor is just there to perform the surgery and move on to the next. So, and I think, to that point, it's really important to look at I think just that there's a fear in our country with the health system that people feel, if I go to the doctor for this, I'm going to lose my house. I'm going to go bankrupt. I don't know what this is going to cost me. And so I'm very, very concerned about that. And that leads to the problem of, I have something that's bothering me and I don't go. And then that can become worse. So something that maybe you would be able to solve in one or two visits becomes something more catastrophic to where now you have a real health issue. So I think there just is a fear out there of people just not wanting to use their plan or go to the doctor because, number one, they don't understand their plan, how it works, and even how to get care, other than I'll just go to, I need a podiatrist. I'm going to go to Google reviews and try to find one. And then I don't know what this is going to cost me. Could this be $100? Could this be $1,000? Could this be $10,000? People just don't know.
Yeah, I mean, that's pretty wild. I mean, we were talking earlier about, trying to find an analogy in the marketplace that is similar to insurance. And it's just, we couldn't come up with anything. The closest we could come up with was like an automotive repair, maybe an engine. Because the mechanic's going to be like, well, I don't really know what's wrong with your engine, but I'm going to dive into it and then I'll let you know later, what it's going to cost. But you still kind of get an estimate. They're like, well, here's how much it costs to replace your entire engine. But if it's something simple, here's the minimum. So you got a maximum minimum. You ask the hospital for a maximum minimum of your surgery and they're going to look at you cross-eyed. They're like, we have no idea.
Yeah, I mean, even the intake or front desk that uses, their job is basically to just verify insurance and send the claim in, and that's all they really do. They're not going to be able to answer that question. I mean, I've been at the doctor's office waiting in line, and I've heard people ask that, and they basically refer to, well, you're going to have to talk to HR. You're going to have to refer to your health plan. And I think as another piece to that's important is where is the payment integrity? Because, since you're not looking at, well, here's my bill based on what I ordered, going back to, the restaurant analogy. Okay, I ordered this, and this, and this is what I'm paying for because I know what I ordered. There's really no way. Once you're in the hospital, you're in the hospital. So just as an example of where, and this is something, as you mentioned, third-party administrators, and something that we do as well, is we are going to review that bill. We're going to review that claim to make sure that it's correct and that it makes sense. So just as a real life example, if you're in the cardiology wing at a hospital and you're having some heart work done, things like that, and let's just say there's not enough room in that wing, and they move you to the ICU just to stay there. You do not need ICU care. It's just they didn't have room, so they moved you into an empty unit. Well, on the bill, you might see an ICU room charge, which is going to be a lot more than staying in the cardiology wing. And with the third-party administrator, with us, we're going to flag that. It's like, wait a minute, you didn't have any reason to be in the ICU. Why are you getting an ICU charge? And so that's a piece of that as well. And the other, if you really look at a hospital bill, and you just compare that to just the prices for some of the basic things, like a couple of aspirin, you might get an $80 charge for that. I mean, you could buy 15 bottles of aspirin for $80. Just gauze strips where the pack is open, they use 2, they throw the rest away, and they charge you $50 for that. So, that's one of the things that is also important when, you really look at the going self-funded and looking at, some reference-based pricing on top of that is it just goes back to that original point around transparency, where if you don't have the actual claim to review and look at, you really don't know where that cost is going. So just in the payment integrity part of it, we can really look at saving the employer some money. And, again, that trickles down to the employees because there's a cost share part of it there as well. Yeah.
So if an employer that is already self-funded, maybe with the Renting the Blues network, you introduce into the conversation, how much do you estimate just, right off the bat that you could save them on claims if they're already using the Blues?
Yeah, it's a great question, and it's going to vary based on utilization as well as the size of the group, the logistics, things like that. Our average, just to give you a nice number, is about 25%. Could be a little more, could be a little less, and it just goes back to the reason where if you've got a group, if your group is with Blue of California, it goes back to that math of you're paying a 50% discount out of that pie in the sky. We like to call it that number of hospitals being able to charge whatever they want and then just slapping a 50% discount. I'll use one more analogy. As you can tell, I do like stories and analogies. So I'll use the outlet market analogy, where you go in and you see a suit and you see all these markdowns, right? That, hey, it's $500, but it was originally $3,300, and then it was half off, and then it was marked down again, and then it's a red tag sale, and I'm getting this $3,300 suit for $500. Yeah. Are you really? Because how do you know it was originally priced that way? That's just the store saying, well, let's slap this price on it so somebody thinks they're getting a really good deal. Yeah. It's the same thing with the charge master price, where you're getting a discount based on what? Just based on what the hospital wants to charge, not their cost, but essentially what they think they can get away with. Yeah. So that's really where the savings comes in. And I like to say with self-funding, it's a crawl, walk, run approach. So just your example earlier where you talked about the group that was spending about $1 million, and you were able to do some analysis, just educate them around self-funding, save them $400,000, big impact to their bottom line. That's kind of that early stage. And then, now as they're starting to see transparency and they're adding, solutions that make sense, they're in the walk to a jog phase. They're almost ready to run. And so that's when we can look at doing reference-based pricing. And some groups, they really want to make a change, and you've got innovative people within the organization wanting to take a look at that. We can do that. But if you're already self-funded, you already understand the concept, and it's a little bit of an easier conversation to have.
So what are the primarily deal killers when you're talking to an employer that is considering going to reference-based pricing?
Yeah, I think it's going to be questions around employee experience. And I think when we talk to CFOs or business owners, they're really going to like the savings, because that really can't be argued. I mean, if we're pricing a claim here, they're pricing a claim up here. Yeah. There's the delta. So
that's what brings them to the table. They're like, yeah, we want to talk.
So really it comes down to, and I love talking to HR people, because their main concern, and really their only concern when it comes to benefit, is what is this going to look like for my employee? Are they going to be able to be seen? What's their billing process going to look like? And I think what's important there is, I just ask, what are your resources today? And you kind of almost get a blank look, like, well, what do you mean? And I said, well, if you have an employee that comes to you and says, I'm having trouble, finding a doctor, or I got this bill that I don't understand, or just any question, their response is, well, there's an 800 number on the card to call. And that's the same 800 number that their employee has. And if you're talking about one of the major carriers out there. It's just hard to get someone on the phone, and it's also hard to establish any real care navigation to where you have somebody that actually can help you through that process. So with reference-based pricing, and you combine that with the third-party administrator that you were talking about before, is you now have real people, you now have resources. So if someone comes in with a question of how do I get care, they have a concierge service. They can call that number. They can talk about what type of provider they need, and the third-party administrator or us is going to be able to provide that type of answer. I can give you a personal example where I was looking for something for my 5-year-old daughter. This is the second one, not the first one, who asked about driving people to the doctor. And I called in. We eat what we cook, so we also have our own reference-based pricing plan at our company.
Yep.
And I, just said, this is what I need. Having trouble, finding a provider that's accepting new patients. Can you help? And not only did they take that off my plate, but they actually found a provider for me. They sent me an email back, and it was actually addressed to my daughter. So my 5-year-old now has her first email. That's a landmark event. And it said not only the provider office.
Is it a Gmail account?
It was not. It was my I-360 account, but addressed to her. So, she's a little young for email, just starting to get getting words down on the reading aspect. But not only did it give me the provider, but it said we talked to Rachel, gave me a real name in the office. All you need, she's verified. All you need to do now is call and make an appointment. So those resources are available. And then if we do have a bill that an employee doesn't understand, we will walk them through that. So if it does happen to be that the bill is incorrect, then it's not paying what it should, then we're going to take that off their plate. We're going to communicate with the facility to get that price correctly. And you're going to have one advocate, meaning you're not going to call and get a different person every time. You're going to get one person that's going to support you and your family to get that bill resolved. Yeah.
So Matt, we talked about deal killers and what employers usually they get nervous about. What other kind of things would an employer say? Oh no, I'm a little concerned, and I'm just nervous about going into something like this because they don't understand it. I mean, you're talking about like as you're getting through the education process, there's usually, and sometimes they're valid. Sometimes an owner says, look, this just doesn't work. This doesn't work for me. And that's fine. But I see that sometimes it's just, they don't understand. Maybe it means you need to have another meeting or a third meeting. I've had some clients that it's taken 3 years to finally transition into self-insurance. And then they look back and they're like, gosh, I don't know why we took so long.
Yeah,
But what other kind of things come up that you can talk to?
Yeah, I think I'll work backwards from what you just said. That the biggest challenge for us is just the status quo. We've done things the same way for 20 years. We've had a recognizable label on the card. Yes, we don't like the increases, but people, it's just natural to be afraid of change, and that I can understand. That this is something new. This is something very innovative, but I think that that's the first part. And we kind of talked about the HR objections to that, where they may not really, they may be frustrated with their plan, but it's the devil you know versus the devil you don't. And so they're going to be very hesitant to make changes. So that's number one. I think number two is that
which very valid.
Very valid.
Across, just from a human element, we don't like change.
I think the second piece that you mentioned is really important, and something that if we talk to an employer and really look at where they're at today, where they want to be, what their challenges are, is we really want to have the education and just understanding of your business. I mean, if you're an employer listening and we end up talking, it's not a one size fits all. I want to understand what your challenges are, because your challenges are going to be different than your competitor down the street. And so I think it just starts with the type of conversation that we're having today of, let's just talk about how we got here. What does the healthcare landscape look like today? Because I think that they know what they're paying. They know they're paying more, but they simply don't know why. So that's the first step. I think the second step is, let's just talk about what's possible. And we can decide if this is something that you want to learn more about. And if that's the case, the finance piece can be brought in, the transition of care, the accessibility, the service aspect can come into play. And you're right. I mean, you do very well. You're an expert in self-funding. So you know that, it can take 1 year, 2 years, 3 years, where people just need to see it a few times before they pull the trigger, and that's fine. We would rather you be committed and be fully invested in doing something like this and want to invest time in the education before moving over, because the last thing we want is to rush something like this out. The employees don't understand. HR is left holding the bag.
Absolutely.
And it doesn't work.
You're like shooting yourself in the foot.
Yeah.
You want it to be well thought out and efficient and seamless, then you're going to be a lot more successful when you make that decision where we've done lots of research and we know this is the year we're doing it.
Absolutely.
We're going to make it work.
Absolutely. And
that's great.
And the employees need to understand the plan too, which I think the education for them is just as important for the education to the CFO, CHRO. You could have the greatest benefits plan in the world, but if you don't know how to access care, if you don't know how to use your plan, you don't see any value in it. But if you have a plan that someone's explained to you, okay, here's what you need to do to get care. Here's what you need to do when you get to the doctor's office. Here's what you need to do if you get a bill you don't understand. Then they're going to feel a lot better about their plan. They're going to know that, hey, they've got my back. I have resources. I have people that I can call. And now I feel more confident in using my benefits plan, which again, kind of goes back to our original discussion and point around retention and attraction. That if you understand your plan, you're happy with it, you're less likely to leave because you don't know what's down the road. That's the unknown part of it.
What about, can you speak to primary care access? Like, how do you address that challenge of getting a network for primary care doctors, or just can you speak to that a little bit?
Yeah, so for primary care, there's a couple things. We do have our own primary care network. So you've got several 100,000 providers nationwide that are easily accessible. Okay. One reason we don't get pushback with primary care if we don't have a label on the card is that for your just basic doctor visits, we're paying at or above the normal rates that they get. And you would say, well, you were talking earlier about paying a lot less. True, but here's where the rubber meets the road is the facility claims where there's those huge markups that we talked about. That's going to be 80 to 85% out of your total cost. So just for making things easier for people to go in and see the doctor, our pricing is going to be very representative of what they're getting today, possibly a little bit more. So again, just quick math. If you have a $100,000 claim, we kind of went through the repricing math, and we save you $35,000 on that claim, but we're paying $50 more for a basic visit. That's where the pricing really comes into play.
No, that makes sense. And if I look at this model and I say, okay, how are we actually saving money? You put yourself in the shoes of a provider. Medicare patient comes in, they're going to pay you $70 for a doctor visit through Medicare. I'm just throwing some numbers out there. Someone with Blue Shield, Blue Cross, United Healthcare, the same doctor visit, they're probably going to get close to $200 for a visit. Reference-based pricing is going to pay somewhere in between. And that is where the savings are. Right. They're getting more than Medicare, and I'd say it's a little bit closer to Medicare than to fully insured rates. But the doctor, the provider is getting paid. It's not as much work and effort, not as many hoops to jump through as it is with the fully insured market. And they're getting paid quickly, and they're getting more than Medicare. I mean, why wouldn't they take it?
Right. And I think it's just, I think a lot of it sometimes is just the lack of understanding where you have someone at the front desk and you present a card that they're not necessarily familiar with. They're going to tell you, I don't know what this is. Not necessarily we don't take your insurance, but I don't know what this is. And that's where the education is important, because that front desk person can call us and we can verify benefits right away. Their only concern is where am I going to send the claim? And so that's where the education comes in, that really all the member needs to do is just tell them, like, here, call this number. They'll get someone on the phone right away and they'll verify insurance to say, hey, here's where you need to send the bill. Take a copy of the card and make a copy, and then just send the bill to us and we'll take care of it.
So give me an idea, a couple of case studies that you have. I mean, do you have some clients that are just raving fans of what you do that have good stories to tell?
We do. Yeah, I think even though we live in a competitive world, once someone achieves success, I think it's human nature to want to help others. And for when we've solved...
I would agree.
Yeah. I mean, that's...
And I tell people I say 99% of people are good people. And then someone corrected me and they said, no, about 95%.
I'll still take those odds.
But, in general, most people are good people. It's just the couple of the bad apples that we focus on. But yes, most employers, like you said, I mean, if they're saving hundreds of thousands of dollars, they want to share. They're like, hey, let me help you save money too.
And I think with that, as we go down the road in the process, if we have people that are wanting to work with us and are interested, we have what I like to call a bank. We've got a lot of great stories to tell. We have testimonials from some of our groups where, again, a lot of those, kind of the example we talked about earlier is, here are my challenges, here's what we did to implement, and here were the positive outcomes. And it's a real story. And we have a lot of those for specific areas or industries, or at the very least related industries, because if you're a construction company, if you're an auto dealership, if you're an ag group, you want to know about what somebody did in your industry, or at the very least something related. But I think even more important than that is we have testimonials from actual employees, which I think can be very impactful, where they're telling their story of being able to get care and not have to worry about this major bill that would have come through. And I mean, we even have someone that has a testimonial that said, I-360 saved my life because I was able to get care. So I mean, again, I think the important piece
Would you connect an potential employer, with one of your current clients if they wanted to get like some feedback or some direct dialogue with someone that is currently working with you?
Absolutely. We do it all the time.
Yeah, that's great. I mean, that is like, look, don't listen to me. Go talk to somebody else that works with us and let them tell you the story, good and bad. They're not going to hold back. Just tell them everything. I don't care.
Yeah, I mean, and I think the references and just having them have access to our service team, our transition of care team. I mean, if we end up having, you and I talk to a group together, they don't want to hear from us sales guys, right? Our part should be 3 minutes, and then we sit quietly.
Yeah, we talk too much.
Yeah, with our hands in our lap. Clearly, with this podcast, I've been talking too much. So,
hey, I do the same thing.
But and I think that's where the comfort comes in, that, hey, these are real people. I'll bring on a relationship manager that will be their relationship manager. So that's an actual human being that's going to work as an extension of their HR. We want to complement what you're already doing well. The finance piece is easy. I mean, honestly, I know CFOs love to get into the numbers and can spend hours on it. We can cover that in literally 3 minutes.
How much money am I saving, and where am I going to spend it?
Yes. I was just at a site visit a week ago, and the CEO wasn't a part of the meeting, but we came in, and he was on his way out, introduced, and the consultant I was with said, they're here to save us money. He said, done right now. Just where's the contract? I don't even care what you're selling.
That's great. I know. Yeah, that's funny. Do you have any municipalities or cities counties?
We do, yeah. So we play well in the public sector as well. So municipalities, city and county, school districts, and again, I'll use the school district for an example where we were able to provide a significant amount of savings, and one of the positive outcomes for them is they were able to hire more teachers. So that impacted their bottom line certainly, but it impacts the students because of instead of say 35 students in a class, you now have 27 or 28, which that's better for the teacher and it's better for the students.
I mean, I think it's great. I mean, not like we talked about. I think it is a great tool for employers to save, hundreds of thousands of dollars. Hundreds of thousands of dollars they can save. Makes their plan, and I see several things. They use that savings to reduce the premiums that their employees are paying. They reduce deductibles and make the plans better, or they use it to go buy a new car or a new fleet vehicle, or upgrades, improvements in a building. But this isn't just an employer conversation. I enjoy talking about this because our system is broken. And one of the things that stands out to me, why is Medicare paying so little? And why do us as working individuals in the United States, why are we paying 4 times for the amount of Medicare for the same services at the facilities? It doesn't make sense. Why?
It just comes down to...
Are we subsidizing Medicare?
Well, I think we're padding carrier and hospital profit. That's essentially what we're doing. So the
hospitals are losing money on Medicare and they're making it up on us.
Yeah, and that's where the system is flawed, and I think there's just a lack of awareness and transparency in that, which is why the self-funding route is so important. And Derek, you hit on one thing that I also think is extremely important to understand just from the employee perspective about lowering the deductible. A stat that maybe just staggering to people out there is close to 60% of Americans are uninsured or functionally uninsured, which means one of two things. Either they flat out don't have insurance because they can't afford it, or what I mean by functionally uninsured is that they have a deductible that they can't pay. So if you have a deductible plan, let's say $5,000, and you have an employee that, average American, what I think, $500 to $1,000 in their bank account. So a $5,000 deductible might as well be $50,000 or $500,000 because you can't pay what you can't pay. And so with a program like this, that's the first thing that we look at when we look at plan design is how can we make this more affordable for your employee? And that's really an easy way to do it because whether an employee, how much understanding they have of their plan, I think most of us understand what a deductible is, and that if you go in, you're going to be on the hook for the bulk of that until that deductible is reached.
Yeah. I've owned my own business before. I've actually owned a few. And I think the takeaway from this is that with the CEOs and CFOs that are busy dealing with big decisions, strategic planning for the companies, mergers and acquisitions, how do you structure the company, how do you grow the company? This is in a very short way is that this is a great tool to provide better benefits to your employees. It's a great tool to reduce costs. It is absolutely getting more popular in the industry, and it's just nice to have options. I mean, nobody wants to feel like every single year I'm getting 10 to 15% increases, and there's nothing I can do. And so even if it's not the right fit for you, as a consultant, I think that it's very important to bring options to the table for an owner to say no. Like, it's okay. You can say no. My job is to bring you options, help you analyze the marketplace, provide a strategic vision of where your plan is going to be in 3 to 5 years. And it's saying no is completely acceptable. But for a lot of our clients, reference-based pricing has been a really, really good solution to save a lot of money. And I think bring control back into your plan. You control your plan. You're not at the whims of the carrier that every year they're giving you these increases and this is the other thing I tell people, they will give you every reason under the sun why they deserve to give you an increase. You can look at your loss ratio, and they'll take in $3 million, and they only paid out $1 million in claims for you, but they always have a reason why they need to give you 10 to 15% increases. Well, inflation. Well, COVID. Well, this. Well, that. Well, prescriptions are up. Oh, the market's trending. And it's just you don't have any control.
You use the right word. It's control. I mean, this is a way to bring control back into your spend. Yeah. And, to your point, this isn't going to be for everybody. I mean, one of the first things that, I'll tell an employer, and the first time we talk is, I don't know if we can help you right now. I need to understand your business. I need to understand your goals, your spend, what's important to you. And at the very least, it's worth having that initial conversation. And it could be a no. I mean, one of the things that I hear a lot is it's not for us this year, more than it's just a complete no for us, forever. It's just, hey, we need to learn more about this. It might take 1 time, 2 times to see it before you end up making a decision. I get it. Change is slow. Sometimes change is fast if there's real need. But I think it just really starts with let's learn more about this. Let's see if there's a match between your business goals, where you sit today, where you see yourself as a 3 to 5 year plan on your benefits as part of that full business structure. And if it makes sense, we can talk more.
Yeah, that was good. I think this conversation is really great. I've really enjoyed spending some time with you and talking about reference-based pricing and some of the issues that we have in our broken healthcare system. But I think that this is going to help provide a lot of education to employers and HR managers on, hey, this is a valid option for you to investigate. So thanks for joining me today. This has been great. I appreciate your time, and I hopefully we can do a second follow-up podcast on, and maybe like a little bit deeper dive into some of these specific areas. So it's been great. I just wanted to say thank you and appreciate the time that we got a chance to spend together.
Absolutely. RBP any day of the week. I'm always ready. Thanks, Derek. Thanks for having me.
All right. Thanks, Matt.